Right, seeing as it's 2 p.m., we're going to get started. Hi, everyone. Welcome to the final round for the youth case competition. My name is Katsi.
And my name is Dale.
And we will be your moderators for this session. In today's session, you will hear 5 different presentations from our brilliant speakers. Each presentation will be about 5 to 7 minutes long and will be followed by a 3-minute question and answer period. After each session, our judges will have the opportunity to unmute their mics and ask any questions they have for our presenters. If there is time remaining, we will open up the floor to the audience to ask any questions.
To our audience, please ask us any questions you have for our speakers through the Whova platform. You should be able to see an Ask Your Question button on the right-hand corner of your screen on the platform. And if you have any questions that aren't covered during this live session, presenters will be able to type out responses in the Q&A box directly.
The winner of the case competition will be announced during the daily wrap-up at 3:45 p.m. PST. Winners will receive a $100 cash prize as well as a feature on our website and social media platforms. In addition, they will have the opportunity to become a youth ambassador for the ACD group and get involved with our lab's research, media development initiatives, and upcoming conferences. And before we get started, I wanted to take some time to acknowledge all the hard work our finalists have dedicated towards the presentations. It's so wonderful to see so many youth involved in today's conference. And with that being said, let's get started. Best of luck to our presenters. Up first, we have Holly and Helia, who will be presenting on the 2-tier action plan combating the opioid crisis in Canada. Holly and Helia, please feel free to introduce yourselves and present whenever you're ready. Screen sharing has been enabled. You guys have the floor.
Hi, thank you so much. I'm Helia. Holly should be. Yeah, she's sharing the screen. I'm in my 4th year of studies in microbiology and immunology. And yeah, Holly is in her 4th studies of speech sciences, and we're gonna get started now.
Yeah, sorry, I'm just trying to share my video. Okay. So yeah, hi everyone, my name is Holly Davies and Helia is my co-presenter, and we are presenting a 2-tier action plan to combat the opioid crisis in Canada. Okay. The opioid crisis has impacted many countries around the world, as you can see by this map, with Canada and the US being severely affected. The numbers show that 1,000 to 3,000 in every 100,000 people have an opioid dependency. In recent years, more than 40% of Canadians older than 15 have used painkillers containing opioids. Drug programs have spent up to $300 million on opioid prescriptions, with $91 million spent on opioid addiction medications. To combat the opioid crisis, the British Columbia Emergency Treatment Fund bilateral agreement has designated a $37.7 million budget, which has been spent on initiatives such as free naloxone kits.
Now let's talk about some of the contributing factors to the opioid epidemic. Initially, the overprescription of opioids for pain relief led to the beginning of the opioid epidemic, as prescriptions did not have sufficient regulation. Following this, the rise of the illicit drug supply increased dependencies and overdoses, with 6,000 overdose deaths in BC reported since 2016. In addition, undiagnosed or misdiagnosed mental health disorders, a lack of education, as well as socioeconomic factors such as poverty, have worsened the opioid crisis. Next slide, please. The supply of opioids has been mixed with illicit drugs, including heroin, crystal meth, and fentanyl. Fentanyl is a synthetically produced opioid, and it's 10 to 1,000 times more potent than morphine. And because of this, it has led to increased mortality in the opioid epidemic. Next slide. Now, what has been done so far? There are free naloxone kits available in most provinces, and the Good Samaritan Overdose Act has been implemented. The Good Samaritan Overdose Act allows for bystanders to intervene in the case of an overdose and administer naloxone when necessary. There have also been other things such as wallet cards in order to increase awareness for the opioid epidemic as well as educate others. Next slide. Now onto our action plan. Tier 1 consists of a mental health screen as well as implementing this in school programs. Next slide. In general, 1 in 3 Canadians experience a mental health disorder in their lifetime, with 50% of these people not having proper diagnosis or treatment. As mentioned in previous slides, mental health disorders such as anxiety, depression, and bipolar disorder are considered to be main risk factors of developing opiate addiction. Many of these disorders are seen in youth and adolescents. For example, the onset of anxiety has been noted to be in childhood and has been deemed to be the earliest form of psychopathology, affecting 15 to 20% of youth. In a similar way, the onset of depression has also been seen in adolescents, specifically between the ages of 12 to 14. While there is a smaller number of children suffering from depression, this prevalence quadruples in adolescents. Bipolar disorder, while rare in children and youth, can also show its earliest symptoms during these ages. And the earlier the diagnosis, the better chance for fighting the chronic nature of the disease, which can contribute to preventing future substance dependencies. This marks childhood and adolescence as crucial times for early diagnosis and thus the prevention of secondary psychopathological problems, which includes substance abuse. Next slide. For these reasons, we're suggesting the implementation of mental health screens for children and youth in order to diagnose those disorders earlier and thus prevent opioid use disorder in the future. To increase accessibility, we suggest doing these mental health screens at schools with counselors responsible for assessing the mental health of students. As many of these disorders have an early onset, we suggest that these mental health screens happen at the age of 8. Depending on diagnosis, the child or youth will be referred to a psychiatrist. Because the prevalence of these disorders increases in adolescence, if a child is initially undiagnosed, we suggest to have a continued mental health screen over the ages of 12, 14, and 16. Also, to better incorporate this into the lives of students, it's important to ensure that both parents and students understand the benefits of this system. Thus, it would be important to add modules with regards to the opioid addiction, as well as mental health in schools, and family education programs and parenting classes. In this way, children and youth will experience a more supportive environment both at school and at home, allowing for more effective treatment and prevention of opioid use disorders in the future. Next slide.
Okay, so tier 2 of our action plan is the creation of an opioid crisis commission. There have previously been recommendations for action made in the form of committees, such as the 2016 Committee of Health Report on the Opioid Crisis in Canada. However, the following recommendations for prevention that came about included reducing opiate prescriptions, as well as an opiate prescription tracking system, which has not been implemented. However, we know that the crisis has developed and the driving factor is no longer overprescription, but rather the illicit drug market. Further recommendations for prevention include more education for youth, families, drug users, and guidelines for healthcare training to deal with the crisis. However, as we have seen in the past 5 years since these recommendations were first made, the steps taken have not been enough. More British Columbians died from the illicit drug overdoses than from COVID-19 in the first 8 months of 2020. Our proposal is for a Canada-wide opioid crisis commission consisting of focus groups which will form solutions and recommendations that will be made to the government. What is different about this commission proposal from past efforts is that it will include those who are directly affected by the opioid crisis, as well as government and mental health professionals who are approaching the situation from a more removed position. This includes family members and friends of those with an opioid dependency, individuals who currently have or had an opioid dependency, Indigenous communities, mental health and medical community members, government officials like provincial health officers, and potentially even those convicted of an illicit drug distribution charge to provide insight into the workings of the facilitators of the crisis and what they have observed. This commission will include focus groups consisting of individuals from each province in Canada, and the resulting recommendations will be made to the government. It's clear that the crisis is changing and evolving over time, so it's important that there be a commission such as this to come up with recommendations suitable for where the crisis is at this point, and to include those impacted because oftentimes they are overlooked as key figures in helping to develop solutions and strategies. That's our presentation. Thank you so much for listening.
So thank you so much to our speakers for such an insightful presentation. And now we'll be moving into a 3-minute question and answer period. Judges, we ask that you use the raise hand function before speaking. And once I call on your name, please feel free to unmute your mic and ask your question. In the meantime, as the judges brainstorm some questions to ask our presenters, we'd like to open up the floor to the audience to send over any questions they may have for our presenters through Whova. There is a Q&A feature on the Whova platform. You should be able to find it on the top right-hand corner of your screen. And once you submit a question, I can read it aloud.
Sorry, I actually can't find the raise hand. It's really not much of a question, but more of a clarification. In terms of the tier 2 recommendation, just so I have a good understanding, the recommendation is kind of like a third party group or commission that would create different focus groups, I guess, in different provinces who would then, would they be province specific recommendations that would be sent up to who? Like where would they go up to? And how would that kind of streamline of communication work? I'm just a little bit lost as to.
Our focus was sort of Canada as a whole. And so what we were thinking of with the focus groups was that they wouldn't necessarily be province specific, because there could be good ideas from other provinces, even if they don't necessarily have the exact same issues that they're dealing with. So the insights should be shared as a whole with every province at the end. So we're assuming it would go up to the federal level of health officials. But yeah, I don't know if that helps clarify.
Yeah, no, absolutely. Thank you.
Okay.
Thank you so much for answering that question. We have one question from an attendee. So given how schools have strained resources currently, how can school counselors be able to get the support needed to complete the assessments?
Right now, I guess what we were thinking initially was just how to make this more accessible. Initially, our plan was just to have psychiatrists kind of do this whole process, but again, like it wouldn't be feasible to have every single child that's in school kind of assessed, because not everyone might want to. But counselors overall, we were thinking like if they were to have some kind of additional training, like with regards to like what they're doing right now, if there could be like additional resources as they're completing their training, like with regards to mental health. We thought that that would kind of be possible, especially with the budgets that the government has right now. I think that we could probably shift some of that focus into prevention in schools. I hope that answered the question. I don't know. Holly, did you want to add anything?
No, I think that pretty much covers it. At the moment, like you can't really expect that school counselors would be able to just take all of this on, but with like over some time, hopefully they would be able to.
And one of the things, this is Carolyn Davison, I'm one of the judges, and one of the things we do know about in-school-based drug prevention is that it's actually best delivered by teachers. And so it's part of that coming up with like a comprehensive school health approach and comprehensive school drug policy, so that students and teachers and parents are all aware of the best policy and supports and pathways to support young people. But I did put in the chat box just a little nod towards a program called Preventure. It's more of a selected or indicated kind of prevention program, and that's where they screen young people into basically types of personalities, and then they are assigned to a certain intervention, and it's been shown to have some success and is used fairly widely in the school districts in the interior of British Columbia. But Preventure, I think, is out of Quebec, and you can look that up.
Thank you. We'll look into that.
The other interesting thing about British Columbia is that the rates of illicit drug toxicity events and deaths are relatively low among young people, much higher among men and people who use at home alone. So I would be interested to understand how your proposal might help those men, who are 80% of those people who are dying are men, and the high rates of people who are using at home alone.
All right, thank you so much to all our judges, speakers, as well as our attendees for sharing their questions and insights. That brings us to the end of our Q&A period. For our next presentation, I'll be sharing a video on a city in crisis, Ottawa. Unfortunately, this lovely team will not be able to join us for their live presentation as they're on the process of getting their vaccines at this moment. However, they will join us later on for a live Q&A session. So now I'm going to start sharing my screen to present their video.
Hi, I'm Talia Lyons. I'm 17 years old and just graduated high school.
I'm Zara Lyons. I'm 15 years old and I'm going into the 10th grade.
I'm Ayla Martin. I'm 13 years old and I'm going into 9th grade.
And I'm Serena Lyons. I'm 12 years old and I'm going into the 8th grade.
We're Indigenous youth from the Wabano Centre for Aboriginal Health. The Wabano Centre is a not-for-profit health centre for Indigenous people. It provides holistic and culturally relevant services to First Nations, Inuit, and Métis people in the Ottawa area.
We're here to talk to you about the opioid crisis in Ottawa, how to recognize the symptoms of addiction, and our solution on reducing stigma because Indigenous people are one of the most vulnerable groups in society.
Too many people are dying from opioid drug use in Ottawa and throughout Canada. Part of the problem is that opioids are so addictive, but we also need to do a better job of recognizing addiction in others and making people feel safe to get help. Common opioids are fentanyl, carfentanil, heroin, OxyContin, and morphine. Opioids are stronger than the drugs our parents grew up with. People can become addicted on their first try, and the difference between life or death from an overdose can be as small as a few grains of fentanyl. There were a total of 74 emergency department visits to Ottawa hospitals for opioid overdose in March 2021. The number of opioid-related deaths in Ottawa had doubled since COVID.
The opioid crisis can affect anyone, like injured or elderly people managing pain, depressed people self-medicating to feel better, and lonely people coping with COVID isolation. When we asked which group of people with substance use problems were stigmatized the most, answers fell into the following categories: people who have used drugs, the underprivileged, and Aboriginal people. The best way to help someone who is showing signs of addiction is to talk to them and see what they have to say without judging them, blaming them, or shaming them. Encourage them to eat better, to exercise, and to manage the pain with the help of a healthcare professional. Ask them to not do drugs alone, and definitely not to mix them with other drugs or alcohol. Build their self-confidence through positive feedback, and ask them to carry naloxone at all times. It's free from pharmacies. If you come across an overdose, don't panic. Shout out the person's name and shake their shoulders. Call 911 if they're unresponsive, then give them naloxone and start CPR. If the naloxone is not working, give them some more every 2 or 3 minutes until help arrives. Don't forget to place them in recovery position.
We've come up with the acronym SWANS to recognize the symptoms of addiction before it's too late. S, sleepiness, W, withdrawing socially, A, anxiety, N, nausea, and S, sudden mood swings. As Indigenous people, we think of swans as a symbol of grace, beauty, purity, strength, wisdom, and healing. Right now, stigma is causing people to use opioids in secret and overdose alone. Stigma is discrimination against a person or a group of people based on inaccurate beliefs, such as they are to blame for lack of self-control. For example, Indigenous people are often stigmatized by society. As long as people are more afraid of losing the love and respect of others, they'll end up losing their lives instead. We need to reduce stigma so that people will stop hiding their use, and the people around them will be more aware of the problem. This way, they'll be more likely to get help before they die from an overdose.
It's important to get people talking about the dangers of opioid use, to teach them how to recognize the symptoms through SWANs, and to give them tools to help. To reduce the stigma of opioid use, this is our solution. Let's pick a national Let's Talk Overdose Day that falls within the typical school calendar. Next, we'll partner with local and national organizations to support and promote this day on their website and their social media. Finally, we'll make a video of interviews showing the impact of opioids on users in recovery and their families. By telling these stories of ordinary people we can all relate to, we hope to reduce stigma and help people see that it can happen to anyone.
A dedicated Let's Talk Overdose Day during the school year will keep the conversation about opioids alive. On August 31st, which is International Overdose Awareness Day, most teens are still in summer vacation mode and aren't thinking of opioids. On Let's Talk Overdose Day, partner organizations could reduce stigma and raise awareness about addictions by sharing our video and visiting schools to educate people about opioids and to train people to use naloxone to save lives.
We want to reach students in grades 7 to 12 because that's usually the age when kids start using drugs. A 2015 survey of over 10,000 Ontario students found that 35% drank alcohol, 18% used cannabis, 14% stole medication, and 10% used opioids. Opioid problems in these kids' neighborhoods and homes have gotten worse during the pandemic. Overdoses in Ottawa have doubled in the past year. School closures, isolation, and loneliness have caused a 70 to 100% increase in local hospital rates for teens' depression, suicidal thoughts, anxiety, eating disorders, and overdoses. Because mental health disorders and substance use go hand in hand. Opioid addiction could become much more common in Ottawa schools and across Canada.
Ignoring the problem won't make it go away.
By doing this, we're hoping to reach people before they become addicted to drugs.
Remember, you can't stop people from using drugs, but you can help people feel more comfortable talking about opioids and teach them how to look for signs of a problem.
So thank you so much to our presenters for such an engaging video. And I see that one of the members of their team is on the Zoom call right now. So similar to earlier, we'd like to open up the floor to the judges if they have any questions.
Hi, Carolyn Davison. I don't know how to raise my hand, but I just want to tell you how much I appreciated your video. And I can see that you're on Zoom now, and I thought you did a great job. And I love your idea. And I'm really interested in what that really would look like in schools and you know, and any other ideas you have about how it might actually show up in your school. But thank you. Great job, girls.
Yeah, I just wanted to say that was a very creative presentation. I really enjoyed the kind of format of how you put that together. Question I had for the group was during the process of your research and putting together your idea, did you have kind of any like a biggest challenge or difficulty that you encountered as you were putting this together?
So I had a lot of problems with my software. Sometimes when I would export it, it would end up messing up some of the graphics or the audio, so I had to redo several parts.
But for the research part, it was not too difficult for us. We just found information on Ottawa Public Health websites.
All right, thank you so much. All right, so now we're going to move on to our next presentation. So I'd like to invite Sahi and Sarah, who will be presenting on behalf of their team. The presentation is titled Straw Education, Stigma, Resilience, and Awareness. Sahi and Sarah, please feel free to take it away.
Hello everyone. Okay, hello everyone. Welcome to our presentation. We are introducing an education program called STRAW Education, which stands for Stigma, Resilience, and Awareness. First of all, we would like to start by acknowledging that
Sarah, I am so sorry for interrupting you. There is a bit of background noise with your mic. I'm not sure if that's something you can fix at the moment or if you have a few minutes to sort that out.
What now? Can you hear me better?
Yeah, that's a lot better. Thank you so much.
Okay. So we would like to start by acknowledging that the land on which we gather is a traditional, ancestral, and unceded territory of the Musqueam people. And we also want to thank the ACT group for organizing this event. So our team, we are 4 students with different backgrounds that met at the Brain Lab under Dr. Christian Suits and that have come together to create this interdisciplinary team. Benjamin has a Bachelor of Sciences in Health Sciences and is starting med school next fall. Kirsten has a Bachelor's in History of Art and is currently pursuing a Bachelor's in Psychology. Sahi has a Bachelor's in Science in Microbiology, and I have a Bachelor's of Arts in Psychology. So as you can see, we all come from very different backgrounds. Kristen and I also come from a perspective from the downtown east side because we're both support workers. So we have this like different perspective maybe compared to academic and scholars. And as we said, Sahi and I will be presenting today on behalf of our team.
Yeah, and just to add a special thanks to Kimia, who is our mentor who helped us throughout our case study.
So last April 14th, Ali Londono became the youngest person in BC to die of a suspected fentanyl overdose during the COVID-19 pandemic. She was only 12. Ali School District has highlighted the need to prevent and delay and reduce substance use, but the only resources currently available are counseling services available to youth 14th and older. The fact of the matter is that while counseling can help individuals cope with substance use, it does not prevent it. And so we believe that working to reduce substance-related stigma in youth could have lasting effects on how youth reach out for help. And in fact, this is how we came together. And because we think that this starts in schools and in education, that's why we decided to do something that comes with an educational program. And so as of now, there are varied educational programs available in place, such as the Project DARE, which targets drug use and during elementary school years. We also have Project Success and TND, which target at-risk youth. However, even though these programs have shown several strengths, there are also missing heavier content related to stigma, resilience, and awareness, which is what brought our group together and what powered the development of straw education.
Yeah, so I'll take it away. As Sarah just mentioned, in order to make up for what's lacking in these programs, we're trying to make up for essentially in the straw program. So this is essentially a timeline that we envision to kickstart the straw program, starting with collaboration with faculty and professionals to sort of get a perspective on the fields of addiction, education, psychology, that sort of thing. Then we would actually implement our pilot workshop targeted towards high school students, ideally reaching to about 5 to 2 BC schools is our goal. And it would include things like worksheets, interactive activities, group discussions, and videos. And also to mention that although we initially envisioned it to be made and targeted for our at-risk youth, we think that concepts like stigma, resilience, and awareness is something that is important and valuable to all demographics of high school students. Yeah, and then in order to evaluate the effectiveness of our program, we were thinking of using a cross-sectional study and attitude-related surveys for the high school students. And ultimately, we envision and strive for systemic change. hoping to get our teaching concepts implemented into the BC curriculum. And starting with youth, hopefully this can be a long-term approach for stigma and prevention, which are two big factors of the current opioid crisis. Yeah, so I'll quickly go over some of the educational concepts that we were thinking about teaching. So first, stigma. We would try to define stigma and elaborate on the different types of stigma, and specifically have an emphasis on the language behind stigma and substance use and addictions and that sort of thing. And then moving on, something that is also not really included in much high school education is the idea of resilience. So we would try to teach this through defining it, sharing and discussing different strategies related to stress and coping, and elaborating on things like mindfulness and personal reflection. And then the last piece is just sort of the overall awareness of the current opioid crisis, and sort of highlighting the different resources, support groups, and organizations that are available to youth and revolve around the current opioid crisis. So this pyramid is essentially a schematic of the organization of our program. So at the top, we would have faculty members and professionals in the areas of like psychology, addictions, education. And as the program directors, which is us, we would hope to receive support and feedback regarding our program and the different concepts we decide to teach. We then would create things like on-campus initiatives, online posting, and events to hopefully recruit and train a group of volunteer instructors who would help us actually run and facilitate these workshops. All right, so in order to actually implement this and have it be successful and effective, programs like DARE often don't have too much in-depth research regarding its effectiveness. So that's something we want to integrate into our program. So we were thinking of running a cross-sectional study with the participants or the high school students that we do run this workshop with a 1, 2, and 5-year follow-up. And essentially we would be evaluating and researching the 3 different areas that we are teaching. So stigma, resilience, and awareness, and doing this through long-term follow-up about like habits related to addictions and mental health, as well as different types of attitude surveys.
Right, so what's next? So we would start by advocating to implement the program into the BC curriculum and collaborating with stakeholders such as the Provincial Ministry of Education, community leaders, nonprofit organization, and external fundings. There's a bunch of considerations to look for. Hi, can you pass? Thank you. Yeah, so there's a bunch of considerations to look into. So for example, the diversity, such as the sociocultural backgrounds that there are in the Lower Mainland. So for example, specialized programs designed for various groups, such as Indigenous communities, South Asian communities, LGBT communities, and so on. And so we believe that our group actually has this strength just because of how interdisciplinary all our team members are. We also have some criticisms and resistance from families. And for that, we would be targeting an ongoing discussion and bringing the families together in a way that would be integrated with this program and the students taking the program. There's also some funding and resource allocation for training and event planning. And we would be targeting this through fundraisers and also online events, which are available to everyone, regardless of where they're located. And then some potential approaches to do that would be team diversity. So as I mentioned, our team is very interdisciplinary and also involving families with lived experience with substance abuse and overdose. So the families of people with addictions and also individuals with substance abuse themselves. These are our references. Everyone can have a look. There's a bunch of them. And well, thank you so much. If you have any questions, please go ahead.
All right, thank you so much to our presenters for such an insightful presentation. I appreciate the amount of detail and thought that went into this presentation. It looks like we have time for one question. So judges, feel free to take it away.
I just had just one question, and I'm not sure if you were listening earlier, but recognizing that teachers are best suited to deliver drug education and curriculum, how do you reconcile that piece of evidence and understanding about drug education in schools with your approach and idea? And how would you incorporate people with living experience into this work?
Great question. I can tackle the first part of it, and then Sarah, you can add on if you'd like. But yeah, so I definitely agree with the idea that teachers would be a great resource and a great, I guess, demographic to have this sort of education implemented. And with what we are doing, we're hoping to sort of get the ball rolling and then have that sort of long-term effect where it is incorporated into the BC curriculum, for instance. And like once it is, essentially that's when teachers would be also like incorporating it into like social studies classes, for instance, or senior planning, things like that. And that's how we're hoping teachers would get involved. And of course, we would also try to collaborate with teachers as well to have their feedback, because I think that would be valuable as well.
And just to add to that, and to answer your second question, how would we bring in people with lived experience? We would be hoping to have support workers and workers of the downtown East Side community, especially in Vancouver, to be helping with these workshops. And so through them, there are actually programs at the different shelters. So for example, myself, I work at a shelter in the downtown East Side, and we have this program where people that have been through the experience, but that have been able to get out of that situation, come back and kind of help and give their own advice and give workshops. And so we would want to bring these people, those with lived experiences that have been out of that life for a while, we would want them to bring their own experience and talk to the students as well. And it would be through support workers and workers of the community.
Awesome. Thank you very much for the thoughtful response. Seeing that it is 2:37, we will be moving on to the next presentation. So thank you very much for the PowerPoint for today. So next up, we have a presentation on e-learning drug education program for youth, brought to you by Noor, Maj, and Jane. So team, you may now start screen sharing and take the floor whenever you're ready.
Hi, our presentation will be on OP, Overdose Prevention Program for Youth. Preventing problematic substance use among Canadian youth is an important public health concern. In the last decade, young people aged 15 to 24 had the fastest growing rates of hospitalization related to opioid poisoning. When asked why they use substances, youth commonly report that they do so to feel good, to be sociable, or to deal with stress and emotional pain. While their initial decision to take substances is generally voluntary, when substance use is initiated early and is continued, youth are placed at higher risk for problematic behavior and harms later in life. While the opioid crisis has been ongoing since 2016, there is still an unmet need for effective prevention and harm reduction programs focused on youth. To develop our approach, we looked into the characteristics of effective and ineffective youth-targeted programs. Programs that have shown minimal effects were often abstinence-based, only focused on providing information about the substances, and had poor fidelity, often due to lack of training, classroom overcrowding, or insufficient time for implementation. Successful programs addressed risk and protective factors of problematic substance use. Common risk factors to reduce are history of trauma, stigma or discrimination experiences, and mental health issues. Some protective factors to promote are resilience, connectedness to school, self-awareness, and having conventional norms about substance use. Other features of successful programs are being equity-driven and meeting the needs of diverse subgroups, including youth as active participants in the development process, and offering behavioral life and social skills training which protect against substance use. With this in mind, we propose an e-learning drug education program focused on increasing empowerment and decreasing substance-related harms in youth.
We realized that there is a need for an inclusive, accessible, and cheap method to prevent overdoses at an early step, especially in the youth population. This is how OPU was founded, a free e-learning drug education platform that is designed for high school students from grade 8 to 10. It will be in Canada, and hopefully we'd hope to expand internationally in the future. OP stands for Overdose Prevention Program for Youth. It will be accessible from any electronic device and only requires an email or phone number. OP collaborates with public, private, and alternative schools to access as many students as possible. The program will start in BC and hopefully will implement it to the rest of Canada later on. We're hoping this program to be mandatory and a requirement to graduate from any high school in Canada in the future. Now, OP will have a simple website with a user-friendly experience. It will also integrate interactive features to make the content and quizzes engaging. We noticed in other programs, the focus was more on the drug education rather than the delivery of that information to youth. So as the content will be mainly educational videos, we realized that we need to engage them and keep them focused while even quizzing them and testing their knowledge. So during the videos, there will be pop-up quiz questions to keep the students focused. And the tests on social and behavior lessons will take the form of situational cases rather than just questions and like multiple choice questions. That way we can prevent cheating and at the same time foster critical and problem-solving skills. Last but not least, we will integrate Kahoot, which is a platform that is very fun for youth and they like it very much. We will work with teachers to implement that in class, maybe twice or 3 times a year. And we'll try to make the content as engaging and use the competitive spirits that high school students already have. Students can complete the lessons at their own pace at home, but they're required to submit tests by specific deadlines throughout the academic year with the help with teachers. Thank you.
Yeah, so next. So our program content will focus on 3 main aspects. First is information about substance use. This will include the history of the war on drugs, stigma and racism associated with drugs, and safety tips. Second, behavioral life skills, which include refusal skill building, conflict resolution, social skills, and emotion regulation. All of these will be using evidence-based techniques derived from cognitive behavior therapy and dialectical behavior therapy, which have been shown to improve any other disorder. And third, positive alternative approaches to substance use, such as risk identification, harm reduction, healthy coping mechanisms, and resilience. Emphasis would be put on fostering good decision-making in youth. Next slide. So we broke down the curriculum into 3 sections, and it's going to start in grade 8. These age groups were chosen because research indicates that intervening in the early years of high school is optimal for delaying and preventing harmful use. So in grade 8, the curriculum would be on the lighter side, and we just want to introduce the subject and define what drug use is and why it could be problematic in today's society. In grade 9, we would teach youth on the history of drug use, signs of addiction, social influences, how to stand up for yourself and reach out for help. And then in grade 10, we will educate youth on the consequences that may arise from drug use. This is the phase where teenagers start going to parties and they start getting exposed to drugs. And so we would want to teach them how to party responsibly and stay safe. We will also go into detail on healthy coping mechanisms, emotion regulation, drug guidelines, and how to use an naloxone kit. So here's an example of a lesson where social awareness will be covered. One societal risk factor of problematic substance use is media representations of substance use. In this lesson, we would go into depth about what is meant by these lyrics by Bruno Mars, for example. So that youth can learn to recognize how media normalizes and even glorifies substance use. They can practice critical thinking skills about the messages popular media conveys and evaluate how realistic they are. We will also use stories of celebrities who have been open about their drug addiction stories and engage youth and keep them interested in the content. Common misperceptions use, such as everyone is doing drugs or alcohol, or that substances are needed to have fun or cope with pain, can be corrected.
To evaluate our program, a pilot study will be conducted with an independent school within Vancouver to examine the feasibility and acceptance of the program. The program will be promoted by teachers and counselors to complete over the school year at the student's own pace. Following completion, students will receive a certificate as well as a survey to evaluate the program. The program will continually be co-developed with youth so that they can remain engaged as collaborators. Our goal will be to partner with schools in different geographic areas to ensure that the findings are generalizable. And the final step will involve implementation into the British Columbia graduation program as a mandatory credential for students to complete. We believe that an e-learning drug education program for youth has the potential to reduce the impact of the opioid crisis by supporting positive youth development and preventing future overdoses. Our program will create a safe and accessible environment that will target early drug and alcohol using youth and empower them to make the right decisions for themselves. Thank you.
Okay. Thank you very much for the insightful presentations. So just like the other presentations, judges, you may now unmute your mics and ask any questions that you have. And for the rest of the attendees, please feel free to ask your questions on Whova and I'll read them out for you once they come in. So I'll give maybe about 30 seconds for the judges to come up with their questions.
Yeah, great presentation. A question from me is, what are the plans in terms of updating information? As we know, the drug markets and scenes are always changing. So what are your plans on that, and kind of how sustainable will that be given this? I'm thinking you're going to roll this out into many different districts. So if you can comment on that.
Yeah, for sure. I mean, the people who'll be giving the lessons are experts in the field. We will always be updating those videos, and that's why it is sustainable. So we don't have to train all teachers around the country on new information. There will be this video that is being updated and being used by teachers in schools or like on the platform. So whenever there's an update, we can just update the video on the website. And that's why it's very easy to do that.
And can I just add one point? So we mentioned co-development. And so after each year, every time we see the results of like the evaluation, we're always going to develop the program to suit the students better.
I have a question. Great presentation. I think this is great. And I love the Bruno Mars, and I just think that makes it a lot more relatable. My question is, do you perceive any challenges or difficulties in rollout? And so I mean, what does it actually look like integrating it or getting it into the BC graduation mandate? And what does it look like actually developing a program like this? And yeah, so yeah, do you guys perceive any difficulties or challenges moving forward?
I can talk about this for sure. So I mean, definitely funding would be a challenge. Finding funding for a platform like this would be a little bit difficult, as we know. So we were thinking, I mean, we can go step by step. We can be hosted on a platform like Coursera or any of those, which could be a cheap option, just to test it out and see how it goes from there. Second thing would be the challenges of just finding the right content for the right age, and that we can learn that by our pilot studies and by our research. So that would be kind of, those are the two challenges that I see coming up.
Just to add on, we wanted to start the pilot study with one school, like a couple of schools at a time, to see how effective the program is, and then eventually grow. We're hoping with more feasibility and acceptance by the students to districts and then to the graduation program. So it's very step by step.
Okay, awesome. Thank you, judges, for the questions, and thank you, presenters, for answering them. So for the attendees, if you have any questions that you would like to ask this presentation, please use the Whova platform and they should be able to answer the questions there. So seeing that the Q&A period time is now up, we'd like to move on to the next presentation. So it is on naloxone plus kits, presented by Jennifer, Rachel, Luce, Joven, and Arya. Without further ado, you may start sharing your screen and take the floor whenever you're ready.
Hi there, thank you so much. Entire screen sharing. All right, just 30 seconds, please. I thought it would allow me to.
By any chance, would it help if I made you co-host?
You can for sure try. I'm using it through the Hova platform, and usually on Zoom, you know how it lets you just share one specific thing. It's just letting me share my whole screen, which isn't a big deal that I'm gonna get rid of.
Okay, no worries.
Is it all right if I join via Zoom? I'm gonna try doing that. Sorry, 30 seconds.
No worries.
In the meantime, I just wanted to compliment all the other ideas that have come along. They seem phenomenally creative. It was so much fun listening to all of these ideas, just because, it's not something you think about every day, but to know that there's other people considering, the same question that is plaguing BC at the moment is really comforting.
We can see the screen, we just don't hear anyone just yet.
Thank you. Yeah, I joined via the Hoover platform and it wasn't allowing me the capabilities, but here I am, technical difficulties aside. Thank you for your patience. Okay, so today we're going to be talking about the naloxone plus kit. So hi everyone, our names are Jennifer, Joven, Aria, Luce, and Rachel. And today we are going to be presenting a cost-effective and innovative solution to help mitigate the current overdose crisis.
So as you may know, British Columbia has been facing a high burden of illicit drug overdoses and overdose-related deaths. Actually, 2020 has had the highest rate of overdoses to date, with approximately 5 British Columbians dying each day from fatal overdose. Individuals on the front line of the overdose crisis have reported that although naloxone kits have averted deaths, overdoses are preventable and naloxone is not enough. In response, a leading solution that we are proposing will incorporate readily available resources, namely naloxone kits and fentanyl testing strips. Naloxone plus kits use a harm reduction approach to encourage people who use drugs to make informed choices about drug use and risk perception. The harm reduction approach comprises 5 core pillars: acceptance, respect, compassion, collaboration, and empowerment. And we will continue to explore how the naloxone plus kits embody the harm reduction pillars into a tangible solution to combat the risk of overdose fatalities.
Please be advised that the next slide contains images of needles and your discretion is advised. So as touched on previously, our solution aims to introduce 3 fentanyl test strips held within a capsule to widely distributed naloxone kits, which gives easy access for illicit substance users to test their drug supply. Within the kit will also be included a small container and water packets in order to dissolve and test a minuscule quantity of someone's drug, and it will also hold an instructional pamphlet including information on what to do if a test is positive and how to reduce false positives. We do not anticipate test strips being difficult to use, with previous studies of drug users reporting no significant barriers to their use and an inclination to keep on using them. However, to reduce hesitation around the use of these strips and to promote accuracy, we aim to include a short educational training module that will be given alongside the training for naloxone administration. We hope that improving accessibility to test strips will increase their use among drug users throughout BC, and we hope that positive test results will increase risk perception among users, influencing them to take more precautions when using illicit substances. There has been hope in this regard as well in many previous studies. So for example, a study from Rhode Island in 2019 showed that many young adults who use drugs reported engaging in various harm reduction practices upon receiving a positive test result. As you can see encircled, these practices included using a smaller dose, using with someone else around, or disposing of their drugs entirely. And these results have really been shown in studies also in North Carolina, San Francisco, and even Vancouver. In Vancouver, the study by Olson et al. Conducted from April to July of 2019, 27% of clients using take-home test kits from Vancouver coastal health sites made a safer choice after a positive test. And data was collected from surveys that were filled on-site after take-home testing results were returned. And the strips in the study also ended up being easy to use and highly adopted, with 96% of clients out of a sample size of 322 saying that they would use them again.
Sure, this sounds like a great idea, but there's really only one way to know if it is. A pilot project, an initial small-scale implementation of the idea that confirms its feasibility. For Naloxone Plus, we plan to approach BC Housing Association with our idea and to request them to provide Naloxone Plus kits to the residents of one SRO or the SROs in a single area, while providing Naloxone kits per usual to other SROs. For those of us who may not know, SROs refer to the single room occupancy units offered by BC Housing for people at risk of homelessness, so as to give them affordable housing options. Needless to say, this is a population impacted severely by the ongoing opioid crisis, and working with them on a pilot project would likely be reflective of the real-world implications of Naloxone Plus. We would then assess administrative data collected annually by BC-CDC within the overdose cohort to come to a conclusive answer regarding the effectiveness of Naloxone Plus kits and the fentanyl test strip kit provided in them. More specifically, we will be comparing the survival rates of controlled SROs with normal naloxone kits to the survival rates of SROs with naloxone plus kits to determine the efficacy of our idea.
The implementation of naloxone plus kits will require multiple stakeholders involved. This will be a collaborative approach involving the BC CDC, BC Housing, and Towards the Heart BC. Currently, Towards the Heart BC and BC CDC are the main stakeholders involved in novel harm reduction strategies that have been implemented across British Columbia, such as naloxone kits and supervised injection sites. In theory, we hope that the BC CDC would assist in assembling the new and improved naloxone plus kits, while Towards the Heart BC assists in distributing these kits to registered sites. BC Housing currently works with Towards the Heart BC by assisting registered sites receive the harm reduction supplies they need. And we hope that BC Housing continues playing this role with our goal of implementing the naloxone plus kits at one registered SRO.
The opioid crisis has cost the Canadian healthcare system an astonishing $3.5 billion each year. That's about $100 from each Canadian. In 2016, the height of the opioid crisis, British Columbia responded by implementing the Take-Home Naloxone program. In that same year, BC removed the $35 cost of these kits and made them readily available to pharmacies, limiting the barriers to access such an important tool in fighting the opioid epidemic. We think adding the fentanyl test strips to naloxone kits will reduce the risk of overdose, as this approach focuses on prevention. Naloxone itself is an intervention if people are at risk of overdose. With that being said, fentanyl test strips just cost $1 per strip and can be directly ordered by the supplier themselves. Currently has been reported, federal funding is starting to consider purchasing these strips. However, how and when they will be distributed is questionable. Therefore, if these strips are purchased and combined with naloxone kits, we suggest distribution will occur more evenly and will provide all the necessary tools to fight overdose in one convenient package known as a naloxone plus kit.
And like Dr. Jane Buxton said, the key to staying safe, even with access to strips, is to be trained to respond to an overdose and to have a naloxone kit with you at all times. And we hope that our approach encourages users to take the necessary steps to prevent an overdose, and if need be, to intervene. I'd like to thank you for your attention and for being such a great audience.
Thank you very much for the presentation. Just like previous ones, judges, once again, feel free to unmute your mic whenever you're ready, and attendees, please use Whova to ask your questions.
Hi, it's Carolyn Davison. Thank you so much for your presentation. One of the things we're experiencing challenges with is that for people who are seeking opioids, the fentanyl test strips only detect the presence or the absence of fentanyl, but doesn't tell you the amount. So just wondered if you had any thoughts about how to bridge that gap between just a strip that might indicate the presence or absence versus what people really need to know is what amount is in their sample.
Yeah, so I can answer this question. I think this approach would be directed towards folks who are not using fentanyl intentionally. And so in regards to your question, I think if folks are using like crystal meth and heroin, they're wanting a cleaner drug supply. So the presence of fentanyl, in theory, should be enough for them to take the necessary steps to reduce the risk of overdose.
I also have a follow-up question. We know lots of people who use drugs now are now gravitating towards fentanyl, and some people are using test strips to actually find fentanyl. Have you considered this when you're putting together the presentation, and like how do you think this kind of comes into play?
I can take this for sure. I think that we absolutely did consider that, and this is absolutely not a catch-all solution. It's not going to solve the opioid epidemic, but in our case, it's a harm reduction strategy that's aimed at helping people who don't want fentanyl in their drugs in order to make more effective choices. Like if they see fentanyl now using with an individual that could administer the naloxone kit that is now with them in case of an overdose, or bringing their drugs to a supervised injection site where there's been absolutely no fatalities ever reported, as I'm sure you know, or just making safer choices in general. If that answers your question.
Also, to further add on to that just a little bit more, within the kits will also be a pamphlet that explains how to use the fentanyl test strips and also what to do if you detect fentanyl in your drugs, whether you want to or not. I mean, whether you intentionally want to use fentanyl or not, there's still steps you can take to reduce the possible harms of using fentanyl, such as Rachel mentioned, having a buddy with you or having a naloxone kit with you, using maybe a little bit less of the drugs than you'd intended to. And so outlining that in the kit itself would probably be something that helps people take better steps in using fentanyl, whether intentionally or unintentionally.
Thank you very much for the Q&A period. Seeing that it is now 3:02 p.m., we were a little bit behind schedule. I just wanted to conclude this session today. So I just want to say thank you very much for coming here. We hope that you enjoyed participating in the case competition and gained some valuable knowledge about the opioid crisis. Before I conclude today's session, I just wanted to remind you that the winner of the case competition will be announced at today's wrap up, which is at 3:45 p.m. And yeah, on behalf of the Addictions and Concurrent Disorders Research Group, I would like to thank our judges, presenters, and attendees for all the time and effort that they dedicated towards today's event. It's really wonderful to see all the youth so eager to get involved and join us as we open this conversation on the opioid crisis. I hope to see you all at the next session. And that concludes this one. I'd like to thank you all once again for coming today. I will be ending this call.